and welcome. Great that you decided to get this preview on the ESVM Congress. And I'm happy that you joined, although I heard there were some technical issues. Sorry for that. I'm Julia Brunner, Medical Marketing Manager at Sigvaris Group. And as part of this team, we always strive to share latest medical knowledge in venous and lymphatic disorders and in compression therapy. Also in webinars like this. And they belong to the series of the Medical Online Hub, short MOH. And in this MOH Talk format, we bring together top-level network of key opinion leaders that present and discuss state-of-the-art topics. Today, we're very pleased to support this preview on the ESVM within the MOH series, and we appreciate a lot that we can do this in cooperation with the ESVM. It's also an honor to have selected speakers on board today, and on top, both the Congress presidents, Professor Mazzolai and Professor Madaric. So big thank you for this great cooperation. I'd like to introduce Professor Mazzolai to you. She received her medical degree from the University of Perugia in Italy, did her research in Scripps Research Institute of San Diego, USA, in the Department of Vascular Biology. And since she came back to Europe, she's been working with the CHUV Lausanne in Switzerland, where 2009 she was appointed as the head of angiology. 2018, she was appointed as head of heart and vascular department, and 2019 as the director of the Center of Malformations and Rare Vascular Diseases. Today, she has almost 400 publications with unbelievable 13,000 citations. And we're very honored to have you here, Professor Mazzolai. So I directly hand over to you. The stage is yours, Professor Mazzolai. Thank you so much.
Thank you very much, Julia, and good evening to everybody. And I'm happy to share this afternoon with my distinguished colleagues. So the idea now is to just say a few words about who we are, what ESVM is, and why you should join us in Milan. And I would like to start with sharing my screen, and I have just a few slides to show you, and so it's gonna be easier for everybody. And the idea really is to say, why do we need to speak about vascular medicine? Why do we care? We care for many reasons, because the burden of vascular diseases is very high, it's underestimated, and it's growing worldwide because the population ages. And just to make an example, if we speak about arteries, peripheral arterial diseases, it touches 1 out of 5 people above 65 years of age. And these people have a very significantly increased cardiovascular risk. Pulmonary embolism is still #1 hospital cause of death, and 1 out of 1,000 people will be diagnosed with venous thromboembolism. 1 out of 3 men will suffer venous insufficiency, 1 out of 2 women. 1% of the adult population will have a vascular ulcer, and 16% of patients with cancer will suffer from lymphedema. So you see how vascular diseases really touch a lot of people, much more than what we actually think. And for that, we need to have a holistic and a comprehensive approach to vascular patients. And this is the reason why we need vascular physicians, and these are highly trained and dedicated physicians that are experienced and specialized on vascular science and vascular diseases. But especially, there is a holistic and comprehensive approach to vascular patients, and the capacity to work in network with other specialists to take care of all these vascular patients that are very heterogeneous. But so a few years ago, particularly in 2014, because of the need of vascular medicine, the European Society of Vascular Medicine was created. And this is an independent non-profit organization, and it's composed of society members, which are the National Society of Vascular Medicine in those European countries that exist specialists and also vascular groups from those European countries where still we do not have a vascular medicine or angiology specialty. We have now 19 European national societies that joined the European Society of Vascular Medicine. And our mission is to reduce the burden of vascular diseases. And you have seen how much those are important. So you will hear from the distinguished speakers of today as well. The idea is to promote scientific exchange, education, research, and very good evidence-based, high-quality practice guidelines in the field of vascular medicine. The idea is also to strengthen the links between the national societies and to encourage the creation of national societies in those countries where it does not exist. And overall, to promote vascular medicine, because this is going to be one of the health burden of the future. So we get together once in a year for European Society of Vascular Medicine Annual Congress. And this year is going to take place in Milan between the 12th and the 14th of October. And this is where all the vascular specialists join forces and discuss together. Indeed, we face many challenges and the burden of vascular diseases is growing worldwide, as you saw, and we need to really get together and there is really the need of a call to action. ESVM 2023 is the place where vascular physicians and researchers get together to share their knowledge and experience and to construct collaboration and exchanges. The scientific committee has gathered renowned speakers and we will discuss a variety of topics, and I'll show you the preview of the program just in a while. We're going to touch on peripheral artery diseases, venous insufficiency, the rare vascular diseases, lymphedema, and also we will cover the full spectrum of vascular intervention as well as preventive vascular medicine. The idea is to offer the best possible education experience to all the participants. We understand that we have to work together in network, and that's why other societies will join us during this Congress. The Society of Vascular Medicine from the United States and the European Society of Atherosclerosis, the International Union of Angiology, and the European Society of Cardiology. And as I told you, national societies are extremely important. And this year, we will welcome two national societies, invited national societies. This is the French Society of Vascular Medicine and the Italian Society of Angiology. The beautiful city of Milan will be the perfect setting for this scientific event. And we really hope that you will join in Milan, and we encourage you to make plans to be with us. So this is the beautiful setting where the Congress will take place over 2.5 days. Our first day on Thursday, you can see that you can touch on carotid arteries. We will have an update on diabetes and microcirculation, of course, venous diseases, some basic science, and peripheral arterial diseases. We will have keynote speakers that will talk to us about vascular diseases in gender and sex. And the second day, we have a breakfast with experts to really discuss what are the unmet needs in peripheral artery disease patients. We will touch on critical limb ischemia, lymphedema, lymphatics, lipedema, and we will have some best abstract communication in our free communication sessions. And we will take care also of the cardiovascular risk in our vascular patients. And finally, we're going to speak about antithrombotics in vascular diseases and venous thromboembolism. And our young vascular physicians have prepared 2 sessions on rare vascular diseases and malformations. So once again, I hope you will join us in Milan, and I'm looking forward to the next presentations from my colleagues. Julia? We're gonna start right away with the presentations.
start right away with the presentation.
Okay, so we divided our afternoon in 3 sessions. We're gonna speak about nutrition and vascular diseases, lymphatics and veins, and then we're gonna speak about arteries. So as our first distinguished speaker about nutrition is Professor Heiss. He's a professor and honorary consultant in interventional and cardiovascular medicine at the University of Surrey in UK. So Christian, it's up to you.
Good afternoon, everybody. My name is Christian Heiss, and I'm a professor of cardiovascular medicine. Today, I'm on vacation in Spain, enjoying a good Mediterranean diet and lots of exercise. And I will talk about nutrition. Nutrition is clearly important for the development, progression, and management of vascular disease. And I believe that there's much room for improvement. We are what we eat. Every day of our life, we put food in our mouth and pass it through our body. Part of it is taken up, part of it comes out the other end. Most of molecules in our body are made from food, and it provides all of the fuel we need to keep cells alive and build new cells. In addition to the basic nutrients and vitamins, food also contains many other molecules that are not strictly needed for keeping the body alive, but may still influence how it works. Important examples are polyphenols and fibers. Do you believe that what you have eaten has shaped how you are today? Do you believe that there is a healthy diet that can prevent vascular disease? Think for a moment about what you ate today, yesterday, last week, last year, and when you were little. Think about all the individual molecules in the different foods that differ more or less with every meal and over many years of life. Consider the many ways it could have influenced your development and may contribute to past or future development of vascular disease. Do you eat too many fries or too little fruits and vegetables? Do you think you drink too much or too little coffee, or eat too much chocolate? How much is too much? Or how little is too little, and why? You can see that understanding the role of nutrition in the context of health can be quite complex. What is clear is that it matters what we eat, and what also matters is what we do not eat. It is also important to understand what makes these foods healthy and why. It is clear that fries do not count as one of your 5 a day. What do patients with peripheral arterial disease eat? Simply speaking, most of our patients do not eat a Mediterranean diet, and surely not enough fruits, vegetables, legumes, and nuts. What is worse is that more than 80% do not receive any nutritional advice from us. One reason for this is that we also lack knowledge and guidance on dietary patterns and individual foods. We need nutritional education programs and patient education in clinical practice. The potential of nutrition to affect cardiovascular health is huge. For example, the randomized controlled PREDIMET study tested in more than 7,000 people with cardiovascular risk factors, but without cardiovascular disease at baseline, the effect of Mediterranean diet with nuts or with olive oil on cardiovascular outcomes. A subgroup analysis of this study, published as a research letter in JAMA a few years ago, showed that Mediterranean diet is associated with lower occurrence of symptomatic PAD. The relatively high intake of fruits and vegetables may be critical for this effect. Fruits and vegetables contain large amounts of polyphenols that are now classified as bioactives due to their pharmacological properties. Besides fruits and vegetables, tea, coffee, and cocoa are major sources of intake in Europe. Epidemiological studies show that higher polyphenol consumption is associated with lower PAD events, including more than 50% reduction in revascularization procedures and amputations. In addition, they can decrease cardiovascular mortality, as shown in the randomized controlled COSMOS trial, decrease blood pressure, cholesterol, and glucose levels, and improve pain-free walking in claudicants. What to expect at ESVM? If you come to the European Society of Vascular Medicine conference in Milan, you should attend the session on lifestyle and vascular disease on Friday the 13th of October between 9 and 10 o'clock. 2 talks will be specifically dedicated to the effects of Mediterranean diet and polyphenols on vascular disease. You will hear the latest evidence on primary and secondary prevention. You will be surprised to hear that the effects on blood pressure, cholesterol, and walking capacity may be in a similar magnitude as compared to common drugs. We will discuss potential mechanisms of action and also summarize what current guidelines recommend, and more importantly, what they should recommend and where the gaps in knowledge are. I hope to see you in Milan.
Thank you so much for this very interesting presentation. I already have a question to you, but I will post that back because I'm interested in the best ice cream in these days. But first of all, let's go to the poll questions. You have 30 seconds time to answer the poll questions, and we will give the right answer later on. And by the way, please use the chat if you have any comments, and please use the Q&A if you have any comments. So I give you a bit time for the poll question, and we will get the results in a few seconds. Okay. What do people with PAD consume very little of? So most people are fruits and vegetables. How do you see that? Is that daily life that you see, Professor Heiss?
I think so. I think so. I think it's one of the major challenges to really understand what people eat. And to me, a big question is really what is healthy food and why is it healthy? And it's as I said, very, very complex. But one of the things that is clear for peripheral arterial disease is that fruits and vegetables are one of the biggies that people do not eat. And I feel that these days there is kind of a paradigm shift from don't eat too much bad things to eat more good things. And potentially this will also change the field. And one important thing is when my patients ask me what they should eat, I should have some evidence to tell them what they should eat, right? And not only give them a flyer. That German study I showed that 80% of the patients do not get any information, and I think that's a low-hanging fruit that we can go for. But the important bit is that we produce also guidelines with that regards and work in that field, and not only tell people to eat fruits and vegetables, because also not each fruit and each vegetable is the same. A banana is not like blueberries, for instance, and there are lots of things to consider.
So are there any comments from the panel? I have a question, if they're not. Are there any differences between the whole food plant-based diet and Mediterranean diet regarding the effectiveness of prevention of CV diseases?
Well, that is a good question. I mean, we have to remember that there is only one randomized controlled trial on the effect of a diet on cardiovascular, and that's the Brodmann study with Mediterranean diet, and the PAD a subgroup was even a post-hoc analysis. So so there is no real evidence that one or the other is better. I see that Marianne lifted her hand. Maybe if she has a comment for that. Now I see Jill's hand.
Jill has a comment.
Yes, I find the whole area very fascinating, and as a blueberry addict, I'm delighted with your presentation. But I think it's also helpful to stress that although, as you correctly said, the evidence in PAD is not absolutely fixed in stone, the evidence for example, the Mediterranean diet for cardiovascular disease in general, which is actually what kills our patients, is very firm. And so what you're saying really should resonate as a general anti-cardiovascular event issue.
Thank you so much also for that input. I think we will have lots of time in Milan to discuss all these things. And now we were moving onwards to the next part, the venous and lymphatics part. And Professor Mazzolai is going to introduce the next two speakers.
Okay, so thanks a lot, Christian, Professor Heiss, for this very nice presentation. And we move on lymphatics and veins. We have two speakers, Dr. Buso and Dr. Fresa. Dr. Buso is a senior physician from Internal Medicine Division at the University Hospital of Brescia in Italy. And he's going to talk to us about lipedema, lymphedema. And then we're going to have Dr. Fresa. He's a senior physician at the angiology department at the Lausanne University Hospital in Switzerland. And he's going to talk to us about management of vascular malformations. So we're going to get started with Dr. Buso and the lipedema and the lymphedema.
Good afternoon, everybody. Thank you very much for the introduction. So my name is Dr. Giacomo Buso from the University Hospital of Brescia in Italy. And during the ESVM Congress in Milan, we talk about a very challenging condition, which is called lipedema. So lipedema is a chronic disease concerning the filament sacs in the great majority of the cases, consisting in abnormal deposition of subcutaneous adipose tissue, leading to bilateral disproportional liver enlargement, typically sparing hands, feet, and the trunk, associated with several symptoms like feeling tired or heavy limbs, easy bruising, hypersensitivity, or even pain with digital pressure, but also spontaneously sometimes. That can lead to considerable disability, daily functioning impairment, and psychological distress in affected women. So the first report of lipedema dates back to the year 1940. But during the next 70 years, only a few have tried to delve into this topic. And it was only during the last 10 years that the scientific community has really begun to study it thoroughly. But despite this steep rise in the scientific production of lipedema, there are still countless issues that we don't know about the disease, including its pathophysiology. So there are several hypotheses in this regard, encompassing the genetic background of the patient, the adipocyte regulation, blood and lymphatic microcirculation, chronic inflammation, as well as a hormonal influence. But the truth is that we still don't know what's going on exactly in these patients. And this is crucial. In fact, because of this, we still don't have any validated diagnostic tools to identify affected patients. So the disease is still highly underdiagnosed, and we don't know its exact prevalence in the general population. But this aspect has also some relevant repercussions in research. In fact, the criteria used to define the disease in the studies available are not always the same. So the clinical phenotypes of the patients are variable. And sometimes you really ask yourself, by looking at these papers, are we really talking about the same condition, about the same patients? So I will show you some very specific example about this during the Congress. But in my view, this could be responsible, at least partially, for the inconclusive findings in the available literature. And this can lead itself to the confusion. This can contribute actually to the confusion about the pathophysiology of lipedema. Ultimately result in the fact that in 2023, we still don't have any curative treatment for the disease. So how can we diagnose lipedema right now? So the current diagnostic criteria are strictly clinical and not so different as those published in 1951 by Wald and Heiss, as you can see in this image. So they include some of the characteristics that I mentioned in my first slide, but also others like no or limited influence of weight loss on pathological fat, minimal or no pitting edema, as well as the lack of symptom improvement with limb elevation. But are these criteria enough to distinguish between lipedema and other conditions characterized by limb enlargement and mainly lymphedema and obesity? Well, as for lymphedema, it is not always so easy to distinguish between the two conditions. In fact, patients with lipedema may exhibit the clinical features of lymphedema, and particularly those with a high BMI. Furthermore, there are several studies using different lymphatic imaging techniques that suggested how patients with lipedema may actually have some alterations in the anatomy and functioning on the lymphatics. And we also know that adipocytes grow significantly in presence of lymphatic fluid. And on the other side, imbalanced and prolonged adiposity enlargement may lead to microlymphatic disturbances. So taken together, all these aspects seem to suggest that there are some lymphatic disturbances that may promote lipedema occurrence, and vice versa as well. But is it really so? Several studies published in the last years, both on the dermal skin and the subcutaneous adipose tissue, have actually failed to reveal striking differences in the lymphatics in patients with lipedema as compared with controls, and nor a striking difference in terms of a T-cell component, which is a substantial difference from lymphedema, where CD4 T cells are thought to play a role in the pathogenesis of the disease. So the two conditions seem to be rather distinct diseases, and probably the disturbances in lymphatics do not play a relevant role in the pathogenesis of lipedema. But it is still possible for patients with lipedema to develop some lymphatic disturbances at some stage at the disease. And the results of more contemporary studies using modern imaging techniques of the lymphatics seem to suggest to confirm this hypothesis, at least partially. So we will talk about all these aspects, as well as the potential role of these imaging techniques in the diagnosis of lipedema during the ESVM Congress in Milan. Just some few words about obesity. Can we say that the subcutaneous adipose tissue is the same in patients with lipedema and in those with overweight or obesity? If the studies on the adipocytes have shown very mixed results in this respect, there are some differences in cell component that emerged, I would say, almost consistently in literature. And I will mention just one of them, macrophages. Macrophages are abundant in the subcutaneous adipose tissue of patients with lipedema, but these are not the typical pro-inflammatory M1 phenotype found in individuals with obesity, but rather M2 macrophages, which are known to be associated with anti-inflammatory and pro-angiogenic properties, suggesting that the adipose tissue of patients with lipedema has actually very distinctive features, making it very different from that of individuals with overweight or obesity. But to further complicate the scenario, obesity is a frequent comorbidity in patients with lipedema. In fact, weight gain worsens lipedema, and the disease itself may increase the risk of obesity. And looking at the epidemiological data, we know that only 3 to 4% of the patients have a BMI consistent with normal weight, whereas over 75% of the patients are diagnosed with lipedema, with obesity, at least according to their BMI. But there is a key aspect that we have to consider in this respect, that the BMI is not a proper tool to detect overweight and obesity in patients with lipedema, as it takes into account the pathological fat of the affected limb as well in the calculation. So the BMI is inherently higher in patients with lipedema, and we need better tool to discriminate between the two conditions. So we will talk about all these aspects as well during the ESVM Congress in Milan. So to conclude, lipedema is a chronic disease with a high burden in the female population. It is largely underdiagnosed, as there is no validated diagnostic tool currently available, and diagnosis still relies on very old clinical criteria. And most importantly, the pathophysiology of the disease is still unknown. So there are still several gaps in knowledge about the disease, but also some very promising novelties. And we'll talk about all these aspects during the Congress. And thank you very much for your attention.
Great. We will have polling later on, but first of all, we will get the next speech for this session. There will be two speakers in this session, and the next speaker is going to be prepared, and we can. Yes.
Dear colleagues,
ready.
It is a real pleasure to have this opportunity to meet you, at least virtually, and share this short presentation that intends to be an anticipation of my talk in the coming Congress. So my name is Marco Fresa. I am an angiologist. I'm an interventional angiologist, and I work in the University Hospital in Lausanne. Just to give you an idea of our experience, I work with patients with vascular anomalies since around 8 years now in a multidisciplinary team, and our treatment volume is around 100 vascular malformations per year. Our hospital is a referral center, and we deal with all sorts of rare vascular diseases and malformations. In In Milan, ESVS Milan, this autumn, I will focus my presentation on venous malformations treatment. And I would like to share with you my passion for this disease. At least I hope to be able to do so, even with this short presentation. I don't know if you also work in a center that deals with vascular malformation, or if you are personally involved in this field. I'm sure that as a vascular practitioner, you will run into some patients with VMs in your career one day or not or another. And I think it's good to know what can be done for them and what is the state of the art. Every patient is different. Every venous malformation is different, and also its response to treatment will also be unique. So I intend to pass in review in the dedicated session in Milan, the diagnostic path and also the toolbox for interventional management of these lesions, including starting from conservative treatment and then also surgery, sclerotherapy, thermal or other ablation techniques. So first thing when dealing with vascular anomalies is the confusion, and it's quite astonishing how difficult it is to give the right name, the right diagnosis to these diseases. You certainly all know that there is a recent classification that is done by the International Society that has updated and revisited many old terms and concepts, but still it happens so often that a patient comes to our attention with a suspected diagnosis of wrong or any old nomenclature conditions as hemangiomas that are vascular tumors, by the way, not malformations, or arterial venous malformations, lymphatic malformations, or even descriptions of cystic formations of some sorts of tumors. And so the right classification, in my opinion, is the first step to address the patient to the right specialists. And this is, in my opinion, also the strength of a multidisciplinary approach. The second step is a good interpretation of any radiological exam, as for example, ultrasound, that is the main diagnostic technique for vascular anomalies. And it's important, very important to know some specific features to distinguish one malformation to another, as you can see in this image. But also MRI or CT scan doesn't always mean clarity. It is true that some vascular malformations may really look alike in these imaging techniques, but be reassured, a distinction is always possible if you know them well enough. And then when we talk about treatment, this becomes interesting. I will talk in my presentation about all the described techniques in the literature, but I will specifically focus my presentation on what is new in the treatment of large and complicated malformations like this one. I'm pretty sure that you can imagine that one thing is to treat this lesion on the left that is already a consistent malformation. It is invalidating, symptomatic with pain, swelling, and recurrent thrombosis, and that is deep located, intramuscular, close to the bone, and in this case that will be dealt with sclerotherapy. But the approach will be completely different if we see this other one that is also intramuscular, but look at the joint and the bone and the muscle involvement that are just massive, and sclerotherapy is not feasible if you want to have reasonable results. So just a little glimpse, a little spoiler of what we currently do in our center for cases like this one that I will describe in details in the Congress, that we do by combining different techniques, and this is in order to achieve the best possible outcome. I will also share my recipe in the follow-up management after treatment of these lesions. So in conclusion, venous malformations are really interesting disease. They have a very deep impact on quality of life of our patients. Most of them are in the pediatric age, and they have a very large spectrum of clinical presentation. You basically never see two patients with the same condition. The classification is mostly underknown. Sometimes is misleading, and so the imaging, and so is the imaging. For example, I'm thinking of all those MRI describing an arterial venous malformation, but then at the ultrasound there is absolutely no arterial component, and the treatment strategy changed dramatically. So that's why I think usually multidisciplinary approach is the key to save time, to save money, and especially to avoid patients to go and see 4 or 5 specialists before getting to the right one. And finally, treatment. Treatment is improving over time, and it should be personalized, tailored. Most of the time now we can combine 2 or more techniques together to offer the best outcome, and the literature is exploding in this sense. So I can't wait to see you in this event, to meet you in Milan. That is my homeland, by the way. Yeah, see you soon, and I'm open for any comments or questions from you. Thank you.
Thank you so much. Another reason to go to Milan. So please, the polling questions for the 2 talks of the last session. Based on the current literature, what is the prevalence of obesity in patients with lipedema? About 50%, 10%, more than 75%. We will also have 30 seconds to answer that question. And you're welcome to ask questions in the chat or in the Q&A. There already is a question in the Q&A. Okay, so could we get the results for polling 2, please? Most people decided for answer 3. You want to state on that, Dr. Buso?
Yes, thank you. Well, I think this is a very crucial point in the context of lipedema. And also with Professor Mazzolai in Lausanne, we really tried to find a solution for this. So actually, the truth is that we don't really know what's the prevalence of obesity in patients with lipedema, because the diagnosis of obesity relies on BMI. And as I said, the BMI is not really the best tool probably to detect overweight and obesity in these patients, because of course it takes into account the fat in the lower limbs and in the upper limbs. And this fat is increased by definition because lipedema involves an abnormal deposition of subcutaneous adipose tissue in the limbs. So I think based on the current literature, there are several percentages reported. The most frequent ones are over 80%, which is a lot actually. There are others much less. In our personal experience in Lausanne, these are not published data, but it's mostly around 50% maybe. But still, what we should really remember is that this is based on the BMI calculation, and this is actually a problem. And we need better tools, and we will also talk about other possibilities during the Congress. I see among the questions that someone suggested actually, or strongly recommended, to use the waist to hip ratio. I think this is one of the possibilities actually to be able to quantify the disproportion between the lower and the upper body, and say, okay, this patient has an abnormal deposition of adipose tissue because of the overweight obesity, or instead of because of the disease, because of lipedema. So yeah, this is a challenging question, but I think that we are far from having a clear answer, unfortunately.
Thank you so much. Maybe there's one additional question from the chat. Are there any data regarding the inheritance of lipedema?
Yeah, so this is another great question, and I think that the answer is yes and no. So there are several reports stating that the inheritance is probably around 60%, maybe more. with a pattern which has been described as autosomal dominant, sex-limited with incomplete penetrance. Sorry. So this means that you just need one of the parents having been the carrier, but you will develop the phenotype if you are female, and not always. So the phenotype presentation is variable. This was also somehow confirmed by a more recent study published in 2022 by a German group, but actually all the studies trying to identify a mutation, a gene, a variant responsible for this have failed to find very striking results. So there are some studies really interesting, but as I said, the conclusions are not very convincing. And I think that one of the problems is the patient selection, because the phenotype used to define the disease is not consistently the same in the several studies. And the other point is that, you know, for this kind of studies, using, for example, genome-wide association studies and so on, you frequently need quite a lot of patients to find something. And if you need to recruit a lot of patients, you cannot be sure 100% that all of them have the same phenotype or the same disease. So this is why, in my opinion, we don't have very convincing results right now about the inheritance of the disease.
Thank you so much, Dr. Buso.
You're welcome. Thank you.
So we're heading to the next polling, please. It refers to the second talk of the session. What is the gold standard treatment for venous malformations? Surgery, sclerotherapy, laser ablation, or there's no gold standard treatment at all? So also, if you have questions here, please put them in the chat or in the Q&A. And I think by now we should have an answer. We have that answer, no gold standard. So would you mind to state on that?
I can just comment because Dr. Fresa is not here. Indeed, it's true. There is no gold standard. And what we have learned and what we're going to learn also in Milan is that we can combine the different treatment strategies like sclerotherapy, laser, or the surgery, etc. And this is really good because that way we can tailor treatment for each patient and depending on the localization, the type of malformations. So no gold standard, but the hybrid solutions, this is definitely something that will be also the future of the treatment of these diseases. And pharmacological treatment, which we did not speak, we're going to probably speak in Milan, but many of these malformations, now we know the genes, we know what the pathway is implicated, and we have some also pharmacological solution that we can combine with some interventional treatment. So yeah, the future, it's brighter than what has been so far.
Great. So we're already coming to the next part, the arteries part. And
okay, so the next set of speakers, this is Professor Brodmann, Professor Madaric, and Professor Belch. Professor Brodmann is the professor and director of Cardiovascular and Peripheral Vascular Research in University Hospital Graz in Austria. She's been one of the past presidents of ESVM. Professor Madaric is the head of the Department of Cardiology and Angiology in the National Institute of Cardiovascular Disease at the University Hospital Bratislava in Slovakia. He's our Secretary General at ESVM. And Professor Belch, she's the head of the Institute of Cardiovascular Research in the Nine Walls Hospital and Medical School of Dundee, Scotland. And she's been just our very most recent past president of ESVM. So Professor Brodmann, it's up to you now.
Yes, thank you, Lucia. I start my screen sharing. Can you see my screen?
Perfect.
Okay, so I'm talking about peripheral interventions in the PAT space, and I will not focus on a discussion surgery against endovascular. I just would like to show data so that you can see what's going on in this field. So there's a development going away from open surgery to endovascular revascularization, and that has been very well documented. As you can see here, especially with the development of new tools, endovascular is getting more and more important, and also has an impact on the amputation outcome. The reason why, and this is a great Medicare overview and survey from 2006 to 2009, showing that if you really do endovascular compared to open surgery, you also can decrease the risk of amputation and death. Why is this the case? In one opinion, or in my opinion, the case for the reason for this is mainly because patients get more and more sick, have more and more comorbidities, and we get more and more patients with critical lymphedema. And critical lymphedema has, as a condition, high risk of morbidity and mortality anyway. So if you do an open vascular surgical procedure, therefore you might increase the risk for mortality. So, and there's another data, so I'm only referring to real world data. So bypass surgery versus stent implantation in patients with diabetics in Taiwan. So a very sick patient population. And once again, you can see that the primary patency, so the efficacy is better than bypass, and also the long-term efficacy is better for stenting or endovascular versus bypass. The issue for that, as I already have mentioned, patients who have PAT are not fit. They really have a high risk of any kind of comorbidities and therefore worsening of these comorbidities. And you can also see here that with regard to this length of stay in the hospital, the stay in the hospital with endovascular is much shorter than with bypass surgery, and that also has an impact on the costs. And I just want to show you a patient which is very often on our ward, or was very often on our ward. She was 86 years old, had dementia, CKT4, orthocoronary bypass, and she also had leukemia. And this is just, you know, from behind, so you cannot see her leg. We had to keep her in the wheelchair, otherwise she was moving. So moving was for her a very important thing, and this was the condition on the leg. And we did, and this were the MRI, and we did an endovascular procedure. So she got the no-go from the anesthesiologist. And the other issue was because she really had the severe infection, should be cut off her leg at the same general anesthesia condition. So, and should we leave her with her pain and threatening infection? So we decided to do an intervention, and this was successful at the end of the day. And what do the guidelines say? I here refer to the ESVM guidelines in 2019. So we had a clear decision in these ESVM guidelines in 2019 that for the aortoiliac lesions, we should go endovascular first, as well as for the fem-pop area. It's a little bit difficult to look about the infrapopliteal arteries. There we still do have some kind of issues. And there is a new trial out there, or there are two trials out there which are discussed very critically, the PACIL 2 and the BASTIL-I trial. And I would say only in a patient where you have a low risk for surgery and where you have a suitable autologous vein, you can then switch to bypass as a treatment first approach, otherwise endovascular first. And there are a lot of new treatment strategies. I just summarize all of them here. And there are more and more in development. So therefore, endovascular is the ideal, I think, approach. There is an issue about drug-coated technology. What kind of drug should we use? The best and most used right now and best tested is paclitaxel. There was an issue with the FDA, which also has been resolved. And we know that with paclitaxel-coated devices, balloons only, we have really good long-term results, and not only in RCTs, but also in real-world registries. And you can see here that also in difficult lesions, we have a benefit. We also have TES, drug-eluting stents, like in the coronary, but not that many. And we also have data for that. We have only 2 right now available, but they do a good job, especially the recent tested one, and which has a better performance. And with regard to what should we do, drug-eluting or drug-eluting ballooning or drug-eluting stenting, we see that both of them are doing well. Regarding this FDA issue, we couldn't find that in real-world data, and in the meantime, FDA has also lifted this kind of issue, so we can treat our patients safely right now and with a good feeling with paclitaxel-coated devices. Another issue which is coming more and more up is calcium, and also here we have new tools like intravascular lithotripsy. Also in the coronary field, this is very common, and if a patient doesn't have any option, we can do in the meantime deep venous arterialization with some kind of system, so making the veins to bypass. This is our treatment algorithm in Austrian. Just to summarize it, we do in all kinds of lesions a good predilatation. If the predilatation was okay, then we go on with further treatment and do a very, very short stent placement if needed. Only if we cannot cross the CTO, then we go to bypass. But also here, more and more new tools are coming with regard to atherectomy. So there are strong forces, in my opinion, for endovascular. First, my only discussion point is that really high quality head-to-head comparisons are lacking, and that we should really also think of what kind of patients we can include in these RCTs to come to a final conclusion. Thank you very much for your attention.
Thank you so much. Really interesting, and another reason to go to Milan. So we can directly go over to the next presentation because we will have time to discuss afterwards in the session.
Hello, good afternoon, dear friends, dear colleagues. My name is Mazzolai Madaric, and I'm coming from Department of Angiology of National Institute of Cardiovascular Diseases in Bratislava, Slovakia. And topic of my talk during our coming Congress in Milan is asymptomatic carotid artery stenosis, if we should intervene on these patients or if best medical therapy should be enough. Firstly, studies from last decade showed us important improvement of carotid artery stenting safety partially because of increase of our experiences, of course, but also because of important technical development of carotid artery stenting. From the second asymptomatic carotid surgery trial published in 2021, we know that severe complications are similarly infrequent after competently realized carotid stenting or carotid endarterectomy, and the long-term effect of both procedures on the risk of fatal or disabling stroke is equal. And these numbers could be even better after double-layer micromesh stents with small eyes of stents and with better prevention of plaque prolapse during the peri-procedural period, which is most important period for carotid artery stenting. Therefore, I will talk more about important road saver study, which was realized with double-layer micromesh stents. Of course, on the other hand, there is also important improvement in pharmacotherapy of our patients, but in real life, a large percentage of our patients, maybe about 50%, maybe it depends from country to country, but large percentage of our patients are not treated according to guidelines despite of decades of efforts. And therefore, the risk of stroke or carotid artery progression in those patients which are not treated according to guidelines is still high and important. But even in those patients with antithrombotic, with antihypertensive and hypolipidemic therapy, sub-analysis of ACST1 study showed us that there is still benefit of endarterectomy in asymptomatic patients in prevention of stroke, and it persists even after 15 years. Another important information I will talk about is results of Oxford Vascular study, which showed us that risk of stroke is related to degree of asymptomatic carotid stenosis, and of course is higher in patients with stenosis more than 70% and even higher in stenosis more than 80%. And I like this algorithm published in Journal of American College of Cardiology, treatment algorithm for carotid artery disease in asymptomatic patients. And therefore I will talk about this criteria and about criteria of higher surgical risk and higher carotid artery stenting risk, and decision which should be done based on these operation risk factors. And of course, another important fact is operator experience, and here I will be a little bit more critical to the data from guidelines or cutoff values and recommendations from recent guidelines. Put it together, firstly, long-term adherence of patients with PAD to best medical therapy is far from the best. Risk of stroke increase with severity of asymptomatic carotid stenosis and is higher in those who are which are more than 70% of stenosis. Carotid artery stenting or endarterectomy in asymptomatic patients are equal in peri-procedural complications, severe complications, and in long-term efficacy. Therefore, decision between stenting and endarterectomy should be based on character of lesions, we will talk more about it, and patient's risk. And there is importance of vascular centers because of this, importance of vascular centers with possibility to realize both carotid stenting or endarterectomy depends on character of lesions and patient risk. And of course, in both cases, experience of operators is very important. And at the end of my presentation, I will offer my view on possible future guidelines adjustment in this field. Thank you very much and see you in Milan.
Thank you very much, Professor Madaric, for this very important presentation. And everyone is probably looking for your recommendations that you will be giving in Milan. So we are ready for the next presentation. Thank you very much.
Hello, ladies and gentlemen. Today, my remit is to talk briefly about cardiovascular risk and peripheral arterial disease. What I'd like to do is to convince you that we need to keep up to date. We need to do the right thing for our patients. And one of the places where we're going to be debating this is, of course, at our Congress in Milan. Now, I'd like to talk, of course, about atherosclerotic disease, and you'll be familiar with critical limb ischemia shown here, chronic form, and the acute form with the white foot after embolization. But of course, more commonly, we see patients with intermittent claudication. That 95% of our patients have intermittent claudication. That is angina of the legs equivalent. It's a very important disorder, peripheral arterial disease, because it affects so many people. It's estimated to be 27 million people in Europe are affected by PAD, and that as our population ages, this will become 36 million by 2030. Now, up until the late 80s, it was actually thought that peripheral arterial disease was a fairly benign disease, and this was because of the benign outcome in the limb. About 3/4 of our patients become stable or actually improve, and very few, 2%, go for amputation. However, all this changed with Michael Creaky's San Diego artery study. And here you can see the death rate amongst a normal population, the death rate in those with low ABI, asymptomatic disease, with claudication, and with critical limb ischemia. And what you can see here is that at 5 years, the death rate was about 25%. And at 10 years, it was as high as 50%, losing half our population by 10 years. And this led us to have a rethink about peripheral arterial disease. Yes, it is a benign effect in the leg. And yes, patients go to their GP or angiologist for management. However, as well as these 100, there's 100 patients who don't seek medical advice. Perhaps they blame it on their back or getting old or whatever, but they don't seek medical advice. And there's a further 100 patients who don't have claudication pain. They may have diabetes and a peripheral neuropathy. They may not walk far enough, but whatever reason, they're asymptomatic. And what's really important is that not just these 100 patients, but these 100 and these 100, all over 5 years, have a significant death rate, the majority of the deaths being cardiovascular. And this is really important because if we add those that don't complain of their pain and those that don't have any pain, the asymptomatic patients, so we remove the word symptomatic, we find that about 81 million people in the European Union and UK are affected, and that by 2030, that will be 80 million out of a total of roughly 550 million people in Europe. So, are we doing any better? Well, these are data here that were published in 2016, so only about 7 years away from now. And what you can see is at 5 years, we still have a 25% mortality. And at 10 years, we still have a 50% mortality. So not very encouraging. And if you look at these data from 2021, these are asymptomatic patients, and this is a relative risk of dying when you have a low ABI. And this relative risk equates exactly to a 25% mortality at 5 years. And here we have critical limb ischemia, figures from 2022. And what you can see is at 5 years, we have that awful attrition of 50% mortality, and at 10, it's up at 35%. So we're not really doing terribly well. And here you can see that if you look at the number of patients dying at 5 years, it's 25%. And actually, you'd be better off having breast cancer, prostate cancer, or Hodgkin's rather than pain in the leg. And in fact, it equates exactly to Duke stage B carcinoma of colon. And if you look at how the cardiologists are doing, over the same time period from the 80s, they have reduced their cardiovascular mortality to 13%. And these are actually 6-year figures, and rather than 5, because there weren't any 5-year figures, but as you can see, it's half what we are with PAD. And of course, it's not all our fault. By the time the big vessels in the leg are silted up, you've got silted vessels everywhere else. But there is a lot that we can do. We need to aggressively treat the risk factors for the cardiovascular events. And here's a list of them, and they're all familiar. And I'm not going to go into them in great detail. We know what these risk factors are. And what we're going to do in Milan is actually look at how we manage these and what's the best way to manage them. Because we know that the more you manage, the actual better the outcome for our patient compared to if we have no risk factors managed. There's a lot of debate on the best management, which we're going to discuss. For example, are e-cigarettes harmful or are they beneficial to our patients? Should we be focusing on high-dose statins, or should we be thinking more aggressively of PCSK9 inhibitors? How do we manage our antithrombotic risk? Is it all about platelets, or should we be getting rid of thrombosis? And we'll be looking at what the evidence suggests. We'll be looking at diabetes. Here you can see critical limb ischemia and diabetes with a death rate at 5 years that almost equates to lung cancer. And we'll be looking at the effects of the newer drugs, such as semaglutide and liraglutide, and looking at the effects of patients with PAD and diabetes. And we'll not just be looking at the drugs we give, but at concordance. And here you can see concordance in statin therapy, and patients who discontinue do not very well. Neither do patients who decrease their dosage, but those that we treat to target do much better. Patients have told me that when they get to 75, their statin is stopped. Well, here's what happens. Here's the death rate on statins. And here, when you stop your statin, your death rate goes back to patients who've never been on statins. So all these things will be discussed in the context of our 29 ESVM PAD guideline. Do we need to update it? Is it still correct? What do we need to do? We'll also be looking at our consensus document that we did with the European Atherosclerosis Society. Again, do we need to improve this, or does it stand as it is? So please do come to Milan. We want to discuss how best to manage risk in our patients. It's complex, but there's a lot of evidence out there. So please come to our Congress and take part in the discussions. Thank you very much, ladies and gentlemen, for listening.
Thank you so much, Professor Belch, for this very interesting talk. And we will also have a polling on this presentation, and later on we will have time for discussing the last 3 talks. So the polling question is, what level of LDL you target in PAD? Less than 1.8 millimoles per liter, less than 1.4, or you do not treat to a target. What does the audience think? We will give you a bit of time, and you're also motivated to ask your questions in the chat and in the question and answer session. So I think we had enough time for the polling. We see the answers. That's not that clear. Answer 1 is the favorite. You would like to comment on that, Professor Belch?
Yes, thank you. 1.8 millimoles per liter was the recommended level to get to. And this was validated in quite a number of studies, which showed that the lower your LDL below that level, the less likely you were to have amputation as well as a cardiovascular event. However, over the past 3 years, there have been other publications showing abnormalities in the genetics of LDL, showing that they are actually quite active molecules and much more liable to be deposited in the peripheral blood vessels. And the recommendation has now changed to 1.4, less than 1.4. The difficulty is that many of us see these patients, and when we have dealt with them, we refer them back to primary care, to general practice, and they never get their cholesterol checked again. And this, I believe, is not correct. I think that we have a duty to treat these patients to the low target, particularly now, if we don't reach target, we have other compounds like ezetimibe and the PCSK9 inhibitors. And we'll be showing evidence why the new level of 1.4 is appropriate at our meeting in Milan.
Thank you so much. Are there any comments from the panelists? Any questions from the panelists? Otherwise, I would just ask or read a question from the chat that is almost answered, and that is referred to Professor Brodmann. So the question is from Fadi Altousin. Thank you very much. What about distal embolism in terms of complication during angioplasty? Maybe Professor Brodmann, you could comment on that. There was a chat ongoing with Professor Heiss, and he also is keen on knowing what you state on that.
as I already have said, is that distal embolization doesn't occur very, very often. The only occasion where you have to fear distal embolization is, for example, if you have chronic total occlusion and you do some kind of atherectomy, but then you have some, tools to protect from that, like filters downstairs. So this is for sure, this can occur, but it's not a severe complication. And in skilled hands, it doesn't occur that often. So this is for sure not a limitation for endovascular first.
Professor Heiss, maybe you also want to comment on that after the conversation with
well, of course, I agree. To be honest, I'm many times very surprised that there are so little embolizations or clinically relevant embolizations. And as Professor Brodmann said, one of the situations where I fear it is, of course, a long chronic, total chronic occlusion and atherectomy. But usually people use filter devices or use special techniques to prevent that. But it's surprisingly very, very rare. Plus, the good thing about angioplasty interventional is that there is always very good imaging, and you will detect if there's an embolism. While during surgery, you may not detect it if you don't do imaging.
Thank you so much. So there's another question. How can we deal with the collateral effects of drugs in order to achieve an LDL lower than 55? I guess this refers to Professor Belch. Thank you.
Thank you. Yes, that is a very key question. I think we all know that if you double the statin dose, you double the side effects, but you only reduce the lipid by another 10 to 20%. What I would say is that if people get side effects, please do check, remove the drug, and then reintroduce the statin. A lot of people read the newspapers, and unfortunately, for some reason, there's a lot of misinformation in our newspapers about how safe statins are. So people will come to us and they'll say, oh, my legs are really tired, and I see that statins do that. But of course, so does peripheral arterial disease. So I would re-challenge, unless, of course, it's something like a myositis. We are lucky now that we have ezetimibe that we can add in to keep the dose of statin low. The evidence for ezetimibe as an additional drug in PAD is not there. It is there for coronary disease. And so we do use it as a first step, basically because it's cheaper than the PCSK9 inhibitors. In many countries now, we have inclisiran as a licensed compound. And as you know, the injections are much less frequent than with some of the other compounds. And so I would shift from a statin to a PCSK9 inhibitor if I had definitive side effects from a statin. I do think that we should try all these. I appreciate how annoying it is the patients having to come back for their injections of PCSK9 inhibitors, but I do think we owe it to these patients, as everyone who gets peripheral arterial disease has a cardiovascular event risk of greater than 10% over the next few years, if you look at the data that I just shown. And in fact, interesting, there's a publication that came out yesterday from the Boston group, looking at patients who had vascular interventions over 10 years up until last year. And very sadly, the death rate is very similar to that I have predicted, I have shown. And so I would stress, try everything. I have a few patients that take a statin every second day, would you believe? It's better than nothing. Do you want
There's another question coming in for you, Professor Belch.
Yes. May I just quickly answer that?
For sure.
And unfortunately, the study looking at rivaroxaban and aspirin misnamed peripheral arterial disease and included carotid disease along with the limb peripheral arterial disease. And that has led to a lot of confusion about what we actually call the disease. But those of us that work there have always called peripheral artery disease your peripheral arteries in your leg. I don't like LEAD because actually that acronym stands for other things. It was suggested by cardiologists, but most of us will talk about lower limb PAD rather than using the LEAD acronym. And we have spoken to the company involved, and they have officially apologized to us for including carotid disease under the term PAD. Whether they'll do it again, I don't know, but that's where the confusion has come about.
Thank you very much. And there's also a question from Josefina in Venezuela. So big audience tonight or this afternoon. Do they perform the ankle brachial index in the population adult for early diagnosis of arterial diseases?
Shall I answer that?
Yes, please. Thank you.
One of the difficulties is that there are many studies, the partner study in the States, the Edinburgh Artery study in Japan, etc., all showing that asymptomatic disease causes problems. So why aren't we screening and treating these patients? Well, the reason is that there is no evidence that treatment works. And you may say, oh gosh, why is that? Well, twofold. Firstly, studies with aspirin have proven negative in many studies in terms of treating asymptomatic disease. However, what has not been done are studies of statins. And so I can't give you any evidence except a gut feeling that if you have asymptomatic disease and you're going to have a cardiovascular event, then if it were me, I would like my lipids lowered. However, there is no study looking at statin treatment of asymptomatic disease, and that is why screening has not been carried out. With Professor Jerry Fowkes, I looked at a calculation study, and we looked at how statins decreased cardiovascular events, and we looked at what we could decrease if we did screen for ABI and if statins were effective. And we actually found that in terms of picking up patients and preventing events, and in terms of cost, we actually, an ABI did better than an FOB test for cancer of the colon, and also did better than cervical screening for cervical cancer. So there's a big study waiting to be done out there in terms of asymptomatic disease. And if I have a patient who is referred to me, then I take it as a marker of atherosclerosis and I will lower their lipids.
Thank you so much, Professor Belch. Are there any more comments from the panelists? Any more questions from the audience? Otherwise, I would hand over to Professor Mazzolai. I thank everyone for the great presentations, and I think it's obvious that one has to go to Milan. And I wish you good success at the ESVM and all the best. And I'm handing over to Professor Mazzolai for the last words.
Thank you very much, Julia. Thank you very much to all the speakers. Thanks to Sigvaris for this great organization, and for all of those of you that followed us during this hour and a half. I think we have learned a few things, and we got more curious to know more about the different topics. So definitely join us in Milan in October. We heard that nutrition plays a key role in vascular patients, and that Mediterranean diet, it's a way to go. It's a start. To know more, again, come to Milan. Lipedema, lymphedema, yet underdiagnosed, underestimated diseases. They are two totally different independent diseases. Still a long way to get the appropriate diagnosis, but we have some tools and we're going to discuss about them. Vascular malformations are frequent. We need to make a good diagnosis, use a proper classification. There is no gold standard in treatment, but a definite panel of interventional and pharmacological treatments to take care of these patients. The PAD patients are not fit. we heard that, and that we need that therefore really a clear interventional, the choice of the interventional treatment becomes crucial, and endovascular is becoming the first choice in many of these patients. How to manage asymptomatic carotid artery stenosis? Best medical treatment has improved, but not everybody is able or is following it, and we know now that with interventional treatments we can still do a lot of good to this patient. There are some options in selected patients. I'm gonna hear more about that in Milan. And finally, PAD is highly prevalent, still not too often diagnosed. We have to make an effort to achieve the best medical treatment and to prevent cardiovascular events in these patients with appropriate diagnosis and treatment afterwards. So I think we have touched a lot of topics. I hope we really suscitated your interest, and we are really looking forward to share some more around vascular diseases in Milan in October later this year. And thanks to everybody.